Welcome to the doc2doc podcast. I'm Rob Hoyer, medical oncologist.
And my name is Abbas Shafi, gastroenterologist. This is a podcast about lifestyle medicine, disease prevention, and longevity.
This podcast is provided for informational purposes only. It is not medical advice. Please consult your physician for personalized therapy and advice.
Our goal is to enable individuals to become CEO of their health by managing their diet, exercise, sleep, and stress to prevent common disease.
Hi, everyone. Welcome to the show. Today, we're going to talk about esophageal cancer. We'll talk about some of the risk factors for this disease and what you can do to prevent getting this condition. And I'll hand it off to my good friend and colleague, Abbas, to start off.
Thanks, Rob. Gastroesophageal reflux disease is a common symptoms. It occurs when the gastric content refluxes to the esophagus and beyond, such as oropharyngeal, larynx, as well as the lung. Most people will experience heartburn occasionally, which is normal. However, if this become a frequent and persistent symptom, then it should be considered medical help as well as to be treated. When we have a meal or we digest or break food, it initially breaks down with our teeth in our mouth, and subsequently through the esophagus, it reaches the stomach, would get further breakdown by gastric enzymes as well as gastric acid. And the stomach can tolerate low pH and high acidity without any disturbance. However, when the gastric content with acid refluxes to the esophagus, the esophageal wall, which is the food pipe, cannot tolerate the acidity, and that's where we experience heartburn and indigestion. This is actually a warning that we have either ate too much, too late, or the wrong food or combination. So that's I'll tell my patient, this is like you're driving your car, and there's a dashboard in your car that give you the warning sign, and it's very important to pay attention to the symptoms. The common cause of esophageal reflux is the volume of the food. Subsequently, the time of the eating, you should not eat 4 hours before going to bed, and then consequently what type of the food we consume. Commonly is the fatty meals, the alcohol, tobacco, chocolate, high dose of peppermints, or a combination of all this food that we have that cause your reflux. Commonly in the anatomy of the stomach, we do not want to consume more than 1/3 of the stomach with at each meal, because when you consume that food, the gastric juice as well as the acid will almost double the volume of what you ate, and you need to have 1/3 for contractibility of the stomach to be able to break down the food further. When any of these things get disturbed, then consequently the acid will reflux to the esophagus and cause the heartburn. Other cause that also can be some people have hiatal hernia or lower esophageal sphincter pressure is low, then can cause the acid reflux symptoms.
Abbas, when someone comes to you with acid reflux or symptoms, are there what makes you concerned when you're speaking with them about their symptoms that they're experiencing?
Well, we try to get a good, accurate history, and the history really helps to see at what level of concern we should be. One of the common one is, of course, is difficulty swallowing, and that be can be related to severe inflammation in distal esophagus or a narrowing or sign of early esophageal cancer. The other one is weight loss. When people, despite the change in diet, they're losing weight as well as difficulty swallowing. That's a double alarming symptoms. The When we look at the patient, if the patient is male and close or over age 50, and that those are the combination of symptoms we concern, as well as the truncal obesity and white male. And if the patient has family esophageal cancer, these are the concerning criteria that make us to do further investigation to prevent esophageal cancer. Of course, the first treatment is the lifestyle modification and maybe a course of medication. But if the symptoms persist, then would consider to do an endoscopy for further evaluation, as well as other studies we can do, like for severe cases, pH studies and an esophagus, which is X-ray of the esophagus done by radiologist.
So, if I came to you with acid reflux symptoms, do you think I should have an upper endoscopy?
No, if there is no alarming symptoms, the lifestyle modification is the key treatment, such as not eating late at night, avoid combination of alcohol, fatty meals, chocolate, peppermint, or eating. So those are the first thing I think should be considered, and even maybe 2 to 4 weeks of therapy, whether with protein pump inhibitor or an H2 blocker, and revisit. However, if there's any alarming symptoms, then at that time the endoscopy should be a consideration to do.
Could you define a little bit of the proton pump inhibitor versus the H2 blocker, and what do they do?
Sure. The Of course, the home remedy for many of this treatment is taking an antacid, which is they're well available over the counter now, H2 blocker, as well as protein pump inhibitor. The the quick effect is the taking an antacid, which is reduces the or neutralize the acid in the esophagus and stomach, so temporary feel, but however it is not for a long time. The second treatment is H2 blocker. H2 blocker is reduces the acidity at a level above the antacids. However, is not as strong as the H2 blockers are the level above the antacid that reduces the acid by a portion of the receptors in production of the acid. However, for past 20-25 years, we have been using protein pump inhibitor, which reduces acidity in a more stronger way, and then consequently prevent from damage to the esophagus and reduces the acidity.
When you do an upper endoscopy on a patient, what do you find?
So the patient when presents with persistent heartburn or any alarming symptoms, when we scope, about 65% of the times actually is a normal esophagus today, because many people, they self-medicate themselves with a antacid, H2 blocker, or PPI. And these are this 65%, about 40% we call non-erosive esophagitis. Other people are hypersensitivity esophagus. Some people they have visceral sensitivity, is a form of like irritable bowel syndrome, as like a functional heartburn. These are people that they feel very uh, acidity feeling, which not really as much as acid production, but it's more of a sensitivity. However, about 20 to 30% of people we see, they have erosive esophagitis. And erosive esophagitis, when the lining esophagus has more than the redness we see, has become more depth and to more of erosion. And we classify those to many different classifications. There were the common one used called the Los Angeles class of reflux esophagitis, and that goes from A, B, C, and D, and that's based on the severity. The concerning ones is the C and D, which is about 19% of the time. Is this not be treated, then this prolonged acid exposure causes Barrett's esophagus, which we see about 3 to 5% of patient with heartburn. They have 3 to 5%. They have 3 to 5% have Barrett's, and to have Barrett, it means a person has been having gastroesophageal reflux disease to the lower esophagus.
Abbas, could you give a little more information about what Barrett's, what that is? That term is used quite a bit, but could you help define it and just describe what you see on the endoscopy when a patient has that?
Of course, when the prolonged acid exposure to the lower esophagus, after many years, the stomach lining will start invading the or extending to the esophagus. That's to a part of human adaptation to acidic environment to, in a way, protect, and people sometimes feels better. And when this lining that extend to the esophagus called Barrett esophagus, and this takes at least about 5 years to develop from chronic acid exposure. And when we see this lining, we commonly do biopsy. And during the biopsy, about 83% of people they have no dysplasia. The dysplasia one means the when the lining of one part of the organ goes, they're called metaplasia, and when it starts moving toward the cancer, they call it dysplasia, as you can explain probably better than I. And off of that, about 7% they have a low-grade dysplasia, and about 10% of people that have high-grade dysplasia or early esophageal cancer.
Okay, so next we'll discuss esophageal cancer. So broadly, there are two main types of esophageal cancer. There's esophageal adenocarcinoma, which is the most common type that we see in the United States. And there's a second type called esophageal squamous cell carcinoma, and squamous cell cancer is seen in both in Europe, Asia, and it has a high relationship to smoking. The well, most of the discussion will be about esophageal adenocarcinoma, as that's what we see in the U.S. But squamous cell carcinoma is also occasionally something that we will see. So, just some key statistics for esophageal cancer. There's about 20,600 esophageal cancer cases diagnosed in last year in the U.S. And as Abbas mentioned, the majority of those are in men. In particular, Caucasian men have the highest risk of esophageal cancer, and lifetime risk of esophageal cancer is about 1 in 125 in men and 1 in 417 in women. So men are about just over threefold higher risk of having esophageal cancer. Overall, the esophageal cancer is a fairly uncommon cancer. I tend to see a little bit more just because that my practice is focusing on gastrointestinal cancers, but overall, esophageal cancer is about 1% of all cancers in the United States. We'll talk a little bit about the risk factors, and Abbas did a great job with mentioning several of those. The big take-home message is that lifestyle is absolutely key for this condition. So the biggest risk is acid reflux, or what we call GERD, gastroesophageal reflux disease, leading to Barrett's esophagus, leading to cancer. And that's the most common way in which esophageal cancer will develop. So basically, anything that will lead to acid reflux chronically will will increase the risk of esophageal cancer. The biggest risk factor that we see is being overweight. So obesity is a high risk of having acid reflux, and that's one of the biggest risks for esophageal cancer. There are several others. The other risk factors, the biggest ones, alcohol and tobacco, are major risk factors. Smoking is particularly associated with squamous cell cancer, but also with the esophageal adenocarcinoma as well. Diet is also really important. So, diets higher in processed meats confer a higher risk of esophageal cancer. That's been well studied. Plant-based diets are likely protective. That's not been proven, but most likely plant-based diets, so eating diets higher in fruits and vegetables, are likely helpful to reduce risk of esophageal cancer. There's also non-reflux related esophageal cancer. This is very uncommon, but related to genetic factors. So there are a couple of genetic syndromes that can predispose to esophageal cancer. Human papillomavirus, that's the virus that causes cervix cancer, may be associated with some esophageal cancers, particularly outside the U.S., and rarely chemicals. So if someone had an esophageal injury, say a chemical burn or to the esophagus, that injury can predispose to esophageal cancer. I'll just briefly talk about esophageal cancer treatment. The mainstay is what we call either bimodality or trimodality treatment. So this is the condition where we'll use surgery, radiation, and chemotherapy for most patients all together. And there's several studies that have shown upfront chemotherapy with radiation prior to surgery is helpful. So we'll usually administer chemotherapy weekly for patients with chemotherapy with radiation for about 5 to 6 weeks, and then follow that by surgery. And when the cancer is very early stage, for example, stage 1, if it has just in what's called the mucosa, the innermost layer of the esophagus, it has not gotten into the muscle layer. Sometimes that cancer can be removed with an endoscope. So endoscopic removal of the esophageal cancer may be possible, as long as that can be done with negative margins. So if all the cancer is removed, that can be done without removal of the entire esophagus. If the cancer has gotten into the muscle layer of the esophagus, usually that requires the surgery to occur. So the staging is really important. So we spend a tremendous amount of time and effort staging our patients, doing PET scans, which is a whole body scan to evaluate for cancer, to make sure the cancer, to see if it's spread to any lymph nodes in the esophageal region, or if the cancer has moved to other parts of the body. So after patients have chemotherapy and radiation, we'll evaluate for surgery, and if the patient is fit enough to undergo surgery, we'll recommend a surgical removal of that section of the esophagus, and that's done by a surgeon called a thoracic surgeon. And that surgeon will go in and remove that section of the esophagus and then reconnect it, sometimes using a part of the stomach, bringing that part of the stomach up to form a new what we call conduit, or a new esophagus for that patient.
Rob, thank you for a great explanation of esophageal cancer. What are the common etiology, or what are the common cause of the esophageal cancer, and how we can prevent it?
Thanks, Abbas. As we discussed before, the biggest thing is lifestyle. So esophageal cancer is one of the cancers that very rarely is related to genetics, and most commonly is related to lifestyle. So we talked about some of the risk factors earlier, and my own personal belief is that it's actually a concordance of these different risk factors in some individuals that can lead to esophageal cancer. We don't know why a person gets esophageal cancer versus, for example, you have two individuals with acid reflux. One gets esophageal cancer, the other one doesn't. Why is that? We don't know. But my suspicion is it's the convergence of these different risk factors. For example, acid reflux, diet, smoking, or alcohol. And together, those seem to, in some individuals, seems to um, uh, seem, will give a higher risk of esophageal cancer. There may be genetic predispositions that we don't fully understand. That's certainly possible. I think the microbiome may be a component of this, and that's why we see that potentially fruits and vegetables are protective for this condition. Something that I've been concerned about is seeing a high number of individuals come in that will need to be on proton pump inhibitors for months or years for their acid reflux. And I've always been concerned about the risk of those individuals developing esophageal cancer and maybe not seeking follow up with a gastroenterologist for endoscopy because their symptoms are controlled, but they maybe have Barrett's or maybe have other findings in the esophagus that would prompt either closer surveillance or even potentially surgery if they have enough changes in the esophagus. Abbas, what do you do in that situation when you say someone comes in and they just can't get off their proton pump inhibitors? What do you tell that patient?
Yeah, it's very interesting. Refluxes for people, the one that actually that develop esophageal cancers are the male, and those are the common when they have very low sensitivity esophagus, and when they um, uh, have Barrett's, actually their symptoms gets better. So these are the people actually. When people have Barrett's, I think we highly recommend to be on some type of acid suppressing for the rest of their life, because otherwise this recurrent erosion to Barrett's and causes cancer. And the people they cannot. The first treatment is of course 3 months of aggressive therapy to heal esophagitis and go back if you have a esophagus grade C and D to make sure there's no underlying Barrett's. If there is, then they need to be on therapy. And for those people, we try to whatever the side effects are very minute, but we educate them on their side effect. And the mostly is the again, as you mentioned, lifestyle treatment. There are if the people they're doing very well, we can reduce the dose of the either protein pump or an H2 blocker. But however, if they have Barrett's, I think they should be at least on low dose of um, protein pump for permanent. And the one that have severe reflux that they cannot be on it, I think they need to maximize their lifestyle modification as well as continue to dose that causes them a minimal side effect. The interesting is not only we worry about esophageal cancer, but majority of the people that have acid reflux disease, and they will have more risk of coronary artery disease and cardiovascular disease than even esophageal cancer. So it's not only concerning to treat the daily symptoms and preventing esophageal cancer, as well as to with exercise and lifestyle modification, not eat late at night, prevent them from other diseases like a heart attack and stroke. And commonly, these people they have comorbidity like diabetes, which further decreases gastric empty. Then again becomes more of a vicious cycle um, for them. Or if they have sleep apnea, with snoring or CPAP, that consequently then can cause us more acid reflux. So it's a syndrome of symptoms that if they early on they go to this lifestyle, again, not only can prevent esophageal cancer, can prevent diabetes, and hypertension, hypercholesterolemia, heart attack, and sleep apnea all together.
Thanks, Abbas. That was really helpful. I think this is a common theme that we're going to find in our discussions on this podcast is lifestyle. And one of the neat things about this is a lot of these risk factors are modifiable. And for the listeners, it's important to recognize that it's impossible to fix everything at the same time. You got to pick one or two things and work on it. And that's what I when I counsel my patients, that's what I say is pick one or two things. For example, losing 1 or 2 pounds per month can make a huge difference over the course of 3 to 6 months. Cutting back
Exactly,
on
exactly. And sometimes
processed foods.
not in late at night, 4 hours before not going to bed and going for a short walk. That tremendously make him sleep better, make him more comfortable, or reducing the alcohol or fatty meals. This is a disease that is, when it says the heartburn is the red lights on the dashboard that is other things happening. So I think this is one of the few diseases that can be really with lifestyle and just this is one baby step at a time. And you 100% agree with you that we it can improve the quality life at present very quickly, matter 1 to 2 weeks, and then a long-term disease like esophageal cancer.
I've had a couple patients in particular as I just think about different discussions I've had with patients that they've converted to either plant-based or even just plant-predominant diets and cut out all processed foods and all the different junk foods, and their acid reflux just went away. And they came in, they couldn't believe they couldn't believe it, and they're off their proton pump inhibitors and lost weight. It's pretty striking to
It
see
is,
that,
it is,
and
it
so
is.
I again, I don't think I don't think it's important that, or I don't think it's necessary to become a vegan in any shape or form, but focusing on adequate fruits and vegetables, and cutting out those processed foods and sugar is absolutely essential for this and a lot of the other diseases that we'll be talking about on this podcast.
Yeah, and the
Any
quantity of the food and what time you're eating. So I think as even if I think eating late at night, my body wants to rest and recombinant position, as well as how much we eat. I think that's another simple thing the patient can, anybody can do. Just simplify those two things and adjust to better diet. And it's amazing how many people, as you mentioned, they cannot believe how they sleep better, how they feel better, how in the morning they're more refreshed and hungry to eat breakfast. So it's easy doable, but you have to do it.
Thanks everyone for listening to the podcast about esophageal cancer. We both really enjoyed making this podcast, and we hope you found it helpful. If you have a moment, please leave us a review on Apple Podcasts or on Spotify. We'd greatly appreciate that. And feel free to share the show. And if you like what you're hearing, please feel free to subscribe, and you'll hear lots more podcasts about lifestyle medicine and longevity. So glad you're here and so glad you found us. Thanks again for listening.